Endosregia 2024 y a nuestro hands-on y no te pierdas la oportunidad de ser parte de este curso que se impartirá en la ciudad de Monterrey, Nuevo León. Este emocionante evento se llevará a cabo los días 1 y 2 de marzo en el prestigioso Hospital Ángeles Valle Oriente. Endosregia 2024 es un evento con ponentes de renombre internacional que no puedes dejar pasar. En esta ocasión nos acompañan los profesores internacionales Dr. Sig Pichamol Girampiñón, Dr. Sergio Sánchez Luna, Dr. Mohamed Othman, Dr. Barham Abu Dayey y el Dr. Román Turro Arau, quienes compartirán su amplio conocimiento y experiencia. El Hospital Ángeles Valle Oriente, reconocido por su excelencia en infraestructura y tecnología médica, será el escenario perfecto para este evento. En Endosregia 2024 tendrás la oportunidad única de participar en el curso Hands-On, que es 100% práctico. El método te permitirá perfeccionar tus habilidades bajo la guía de expertos en la materia. Esta experiencia práctica enriquecerá tu formación profesional y te permitirá enfrentar los desafíos de la endoscopía de manera efectiva. No te lo pierdas. Cupo limitado.
Hello, welcome to the first session, monthly session from the Mexican Association of Gastrointestinal Endoscopy. This time around, I would like to introduce Dr. Guillermo de la Mora Levy, our president, and Dr. Ulises Escalante, who will be the moderators for this session. Thank you very much.
Buenas noches.
Hello, good evening, everyone. Well, this is our first session for our session that is for this year, 2023-2024. You already know it, Dr. Eduardo Torices Escalante, who will be moderating these monthly sessions throughout this year. I am present here today because this is the first one. This is in order to start the cycle of academic activities. This time around, we have Dr. Norio Fukami. He works in the Mayo Clinic in Scottsdale in Arizona. He has a very peculiar story. I find it truly to be admired. He is Japanese and he studied everything in Japan, the whole career, and specialized in internal medicine, gastroenterology, and endoscopy. He even worked as an attending physician in Japan. He graduated from Kyushu University in Fukuoka. And after some years, he went and visited the United States, and he had to repeat everything: internal medicine, gastroenterology, and endoscopy again. So we have the opportunity of having with us somebody who has both the experience from Japan and also the current technology that they have in the United States. So we will begin this presentation with Dr. Norio Fukami. Dr. Fukami, you may begin. Thank you very much.
Is it okay? Hi, buenas noches, everyone. Thank you for your kind introduction. I'm at Mayo Clinic, Arizona, neighboring state to the Mexico, and I'm privileged and honored to be here to talking to you about the endoscopic resection in the colon. I will walk you through from more basic to how to evaluate and what the possible solution to remove the polyp. So I'm happy to take any questions, and let me start the lecture. There you go. So the polypectomy is a common method to remove the lesion in the colon. Initially, there's a normal snare, just a little lasso was developed, and later stiffer snares is actually better for cushion-assisted, fluid-assisted tissue resection. Is now called EMR. And the injection needle is incorporated in some time, and now special snares for cold snare, special snare for cold snare is available. And looking back the history of resection, this simple snare removal was started in 1968. That's even 1 year before we landed, or not we, but human landed on the moon. Later on, injection really helped to elevate the flat lesion so that you can capture them. Double channel to pick up and put the snare around was developed. Everything to cope with the flatter lesions, not like polypoid lesion. Now, to assist complete resection on those more flatter lesions, band and resect method and CAP EMR were developed in 1993. And now it's popularized. The band and resect is much more popular currently, mostly in rectum and esophagus. And this endeavor to fare this tissue resection as surgery, we're trying to save patients from surgery so that we can completely remove the lesion from precancerous to cancer. And that journey led Japanese physicians to develop the technique now called endoscopic submucosal dissection. It was developed in 1990s, and kind of over the decade, it's evolved and perfected, and now it's much easier to perform than initially developed. ESD proceeded to go deeper. If you cut the muscle, we call the EMD, endoscopic muscular dissection. And if you go one step deeper, it's called subserosal dissection. It's dissecting between the serosa and the muscle. That can be really challenging, but that was proposed as well. We have a method to remove the full thickness. Using a knife, just cut through the wall, intentionally perforate and close. Or FTRD, full thickness resection device, is developed to close it first with over-the-scope clip and resect over the top, but still offer full thickness resection in many occasions. For submucosal tumor, submucosal tunneling endoscopic resection, or POET, peroral endoscopic tunneling resection were developed. And this is mainly used for a submucosal tumor or stromal tumor, such as GIST or symptomatic leiomyoma. Now, first thing, when we identify the polyp or lesion in the colon, we have to classify what type of lesion they are. And this is a common language we use between the physicians, and we have to be able to communicate in an effective way. So the Japanese classification was adapted at the meeting in Paris, and now it's called the Paris classification. Protruded type is called 1S, 1SP, or 1P, depending on how much of the stalk you have or how high it is. Superficially elevated ones are called 2A, flat type 2B, and depressed is 2C. If the 2A lesion is larger than 10 millimeter, typically it's called laterally spreading tumor. And typically there are two major types, granular and non-granular. Nowadays, there's a mixed type, which is a granular, but have multiple different sizes of granulation, granular nodules. These S1, SP are most commonly seen, but the granular, non-granular type LST were found relatively common in a larger size. If you look at the non-protruding type, it was reported to be about 10% by Sutikno's report in 2008. At the surveillance, we see a much higher rate of non-protruding type. So we have to be really careful when we do survey patients for history of colon polyp. We have to keep an eye on flatter lesions, not only the protruding ones. To aid diagnosis and discovery, chromoendoscopy has been used for many decades. This is the way to enhance the surface structures or characteristic of the vascularity by contrast, creating a contrast from normal tissue color to the adding color, or just actively stain the surface layers. This is in the gastric antrum, and we're able to identify this subtle change. This is actually a high-grade dysplasia here, hidden as a depression. This lesion protruded, a little reddish, and this is a little nodularity with some red erythema. If you use the chromoendoscopy, typically here is indigo carmine, what it offers is enhancement of these crevices. So we can see the surface pattern much more clear. These are normal area, and this is really abnormal. So we can define the lesion much more effective way. The other thing is the contrast really enhances redness. Redness is vascularity. So any neoplasm has much more increased vascularities, abnormal corkscrew, thick vessels, it's the neoplastic vessels. Those are shown as redness. So we can identify these abnormalities by more red enhanced images, and the surface pattern is so abnormal. So this really enhances the demarcation of the lesion. There are many ways to do chromoendoscopy. Indigo carmine is used typically at the 0.2%. You can use a much thinner or thick, but if it's thicker, it's going to be blue all over the place. It's very difficult to see. And this is a contrast method. If you want to wash it off, you can just wash it off really easy. And you can apply again to really look at it. This is the blue dye just pooling within the depressed area, the crevices. Other chromoendoscopies are vital staining. Lugol solution is used for squamous dysplasia. The normal squamous cell is usually gets stained because it's glycogen-rich cell. So the Lugol solution would stain the glycogen-rich cell itself. The brownish area is normal. Unstained area is a dysplastic area, so we can really demarcate. The earlier report, if you do the Lugol staining, the abnormality increased by 30%. So you typically underestimate without the chromoendoscopy. Methylene blue is an active staining. It stains absorptive cells, which is intestinal type. So it's being used for small bowel, Barrett's esophagus, that's the intestinal type mucosa, and the colon. The issue is that the methylene blue stains the mucus at the same time. So it gets really tricky. You have to really wash before you apply methylene blue. Otherwise, you see a lot of spotties, the staining as well. The method for chromoendoscopy is acetic acid chromoendoscopy. This is like vinegar. You can dilute to 2.5%. And it actually being used well in the Barrett's esophagus. It causes disruption of the mucus, so you can take off the mucus a much more effective way. And then whiten this epithelium, showing a pattern much more effectively. And later, some of the vasodilation occurs, so some of the redness is being enhanced when the whitish change disappears. But that's not for the colon, actually. For the colon, pit pattern is well described, proposed by Dr. Kudo at Showa University, Northern Yokohama Hospital. He proposed that using a chromoendoscopy and magnification, you can really separate normal tissue type 1 and hyperplastic type 2 from adenomatous precancerous, which are the tubular pattern 3L or gyrus or branch type 4, which is tubulobulous adenoma typically. And type 3 is a very small pit compared to the normal pit. This is a typical finding for depressed type lesion, like such as 2C lesion. If the surface pattern gets really irregular, sometimes it's difficult to see with just only chromoendoscopy. So typically, the crystal violet is used to stain the nucleus, and to show really irregularity on the magnification. If you see the irregularity, that suggests a cancer or maybe early cancer. If you have non-structured pattern, it's a destruction. This is typically deeply submucosally invasive. So those findings usually separate patient to the surgical arena. We can do the advanced imaging in addition to chroma-endoscopy. Nowadays, almost I think all the endoscopic the tools have this additional optical or electronic chroma-endoscopy capability. One is the narrow the wavelength. It's called narrowband imaging, or digital imaging post-acquisition processing. They get the different color scheme images, return to the computer and reprocess and produce different type of color scheme. So that's two major differences. One is to change the wavelength, the light itself, or just a process what type of color returning to the computer. And these are the one button push, and you can enhance the vasculatures. You can see the surface pattern better. And this is taking over chroma-endoscopy, but I still use the indigo carmine dichroma-endoscopy for certain occasions. If you cannot see well, that's really a great adjunct to the diagnostic capability. When we use this optical chroma-endoscopy, NBI has been mostly investigated. And in 2013, a group of physicians worldwide met together and created this nice classification. And this actually separates non-neoplastic to neoplastic polyp, and in addition, more deeply invasive cancer. So their simplified version, this is non-neoplastic, adenomatous, or cancer. And it's a simplified, but you cannot really separate the important distinction whether endoscopic treatment or surgery. It's a little bit difficult to differentiate. But however, you can call it a type 2 with a brownish, means it's much more vasculature. The surface pattern is a tubular. This is the type 3, consistent with type 3L pit pattern. And then you can see sometimes a gyrus branched pattern, that's type 4L. And then that would be called type 2. So that's an endoscopic treatment criteria. You have to go ahead and take it out. If you see type 3, that means disrupted surface pattern, really amorphous. You cannot really see the pattern. And then these vasculature corkscrew, different calibers. If you see that, it's most likely invasive to deep SM, so you cannot really cure endoscopic resection. So that pushes the surgical resection. To separate those endoscopic versus surgery much more precisely and effectively, Japanese physician proposed another criteria called JNET classification. The major thing is they separated type 3 in nice classification to type 2B and type 3. The type 2B is probably high-grade dysplasia, potentially early submucosal cancer, but it's still probably more suitable with endoscopic resection. And then we can stratify a patient, whether the patient would need additional treatment like surgery or not. And this is shown by the irregular or sometimes obscure surface pit pattern, but it's not destructive. And the variable caliber vessel pattern you can see, but it's not the blood vesselless or thick vessel or irregular vessel. So if you see these really abnormal vessels, those are typically deeply invasive. We call type 3 in conjunction with destructive surface pattern. WASP classification separate hyperplastic to sessile serrated adenoma polyp. There are two classifications: traditional serrated adenoma or sessile serrated lesion. These were typically seen as a clouded surface. You cannot really see the border. It's very difficult to see but this mucus cap is seen. Sometimes you can see some laced vessels, and it's a larger area. The typical SSP has these dark spots inside the crypt. You can see those dark spots, like, and once you see that, this is, yes, it's a self-separated polyp that deserved endoscopic removal. It's not hyperplastic. So that's really useful, separating whether we should take it out or not. Once you have those knowledges, you start inspecting a lesion. Does this polyp have deeper invasive cancer? Is it okay to take it out? Are we helping patient by removing it? And you have to evaluate both sides. You can see from straight view, but you have to look backward because something often hidden behind the scene, and deeper invasion may be on the deeper side, not on the surface towards you. You have to see the fullness of the stalk. This is nicely thin. So this is probably not the invasive cancer. Let's go ahead and take it out. If you see this polyp, it's not that big, but it's a little bit thick on the height. And if you do the deflate the colon, you can see the configuration hasn't changed. This is represents stiffness of the wall. So now we're suspecting deeper invasion. If you do NBI and you didn't do magnification yet, but you start to see some destructive pattern, different preserved and destructive. So if you start seeing this, carefully do the magnification evaluation, you start to see type 3 nice and genuine classification. So then you shouldn't touch this lesion. You have to send to the surgeon after tattooing proximally and distally, yes, if appropriate. So those are the inspection of lesion. This is a little break. Which one is more advanced? This is a polyp we found and activate the near focus with NBI. You start to see this surface pattern. Is there any abnormal vessels, destruction, or any depression? And if you look carefully, there's a little depressed area. And frequently I get called, well, this is a depressed area. This is really concerning. Now let's take a look at this one. Let's move forward. Now, this is small 8mm polyp, but you start to see that this area is normal pit, but you start to see somewhat irregular, but center is very irregular. And it's really looks like it's depressed areas present. So those are the two different lesions. So this is the older NBI, this is a newer, much more clear. So which one is more concerning? This is the answer. Actually, left side is called pseudo-depression. Sometimes you can see this starry depressed area, but it's the center is really not destructive, not small. It's pretty similar to others. This one has a really destructive, very small pit pattern. If you get really close in the more modern endoscopy, you can see type 3, type 3S pit pattern. It's very small, dense, and this is actually entire lesion was high-grade dysplasia and 8mm. So let's look at the risky signs that it has more invasive cancer. We talked about lost pit pattern, depressed area. Those are really high risk for having invasive cancer. If it's a LST granular type, large nodule is a risky, non-granular type, wall stiffness, or the larger size itself increase the risk of having cancer. And these proposed criteria from Japan was confirmed by Australian group, and they pretty much endorsed a similar finding, but they added rectosigmoid location is much more aggressive than other location. These are typical findings in the paper with Dr. Rauka's published. This is a large nodule within LST granular type. This is really risky for cancer. Depression at the center. This shows wall stiffness. It's not smooth. It's just a little stiff like that. And this is showing convergency. It's kind of pulling towards the center. That's typically what it does is invasive cancer retract the muscle and also creating dense stromal reaction and create the convergency. Chicken skin appearance. Sometimes you see the white speckles around the lesion. That is actually signs of more higher grade dysplasia. Or sometimes villus tumor has this sign. So villus tumor to high grade the cancer, you have to see which one exactly it is. It's not indicate invasive cancer, but it shows a high risk. It is actually lymphocytic follicles that reacting to this neoplasm. If you see invasive pattern is a certain area has lost the surface pattern or was very irregular. If there's a certain area that perceived, this is called invasive invasive pattern. It's typically deeply submucosal invasive or T2. So this is not indication for endoscopic resection. Quickly showing that these polyp, this is a flat LST non-granular type. This looked like a little stiffer, but actually it was not stiff enough. If you deflate, inflate, you can see the consistent the wall difference. I mean, folding of the wall. This is a little bit stiffer appearance, but by biopsy in the past, this is just the adenoma. You can see a whitish speck. So you start to wonder what it is, and you have to really look at the center. And if you take out the mucus, you start to see the clear depressed area. This is the submucosal invasive, little over the curative criteria. So this patient went to surgery, but there's no lymph node metastasis. Once you determine the best way, determine the suitability for the endoscopic resection, now you have to decide how you're going to take it out. Cold snare, hot snare, of course, unblocked piecemeal you can do. Underwater EMRs is really useful technique in certain method, certain situation. And the conventional EMR, ESD, and of course, surgery. You have to really think what the situation you're in. Is the patient well informed with the risk of removal? Is the patient condition allows to continue on to the removal of the large lesion? Is large lesion contains potential high grade? Maybe it's suitable more for advanced resection. And those are decisions you have to make. If you know this is adenoma type 2, nice classification, type 2A, 2B, JNET, you don't really have to biopsy. And biopsy can cause fibrosis underneath, making complete resection difficult in the future. So we're trying to emphasize that if you're comfortable with diagnosis of precancerous adenomatous change, then you don't really have to do the biopsy to send for referral for advanced resection. And we always see the patient before the procedure, discuss risk and benefit, alternative to the surgery, and what's going to happen after the resection if the lesion shows deeply invasive cancer. Okay, so cold snare has been really helpful removing a smaller polyp. 3 to 5 millimeters is really suitable. In the tiny polyp trial, 1 to 3 millimeter polyp was much easily removed by large capacity forceps. But of course, you can use the cold snare. The cold snare benefit is actually the thin snare, the stiff enough to because it's braided. So you can repetitively use it, but it's thin enough to cut through the tissue quicker. And it's much more useful for a cold snare. You can use hot snare for cold snare, but it gets difficult to cut through. 5 to 9 millimeter is endorsed to be removed by a cold snare polypectomy by multiple societies. And we tend to do that. We extend to up to 9 millimeter to remove the polyp by cold snare because the lower risk of bleeding, delayed bleeding, and it offers much more complete resection than forceps in many cases, larger than 3 millimeter. Now, Dr. Rex did a randomized control study, and he's more of an advocate of cold snare. You can do piecemeal cold snare up to 15 millimeter, and it offers shorter time, but it tend to be smaller pieces. For some reason, in that study, hot EMR showed much more residual polyp, and Dr. Rex couldn't really answer why this happened. But this is including multiple practices, the academic to the common practice. So he couldn't really tease out why this happened. More than 20 millimeter is where we have to really discuss what's the best way to remove it, because there are so many options we can offer. When you do the cold piecemeal EMR, many advocate using a diluted epinephrine because cold snare causes immediate bleeding. Diluted epinephrine helps seeing the polyp, reducing immediate bleeding during the resection. Underwater EMR was proposed in 2012 by Dr. Ken Bimbeller, and this has been really game changer in certain polyps. He described that with the EUS, when you collapse the lumen, you can see all the folds are floating into the water, but the muscles remains like round. So when you put the snare around it, there's no way you can put capture the muscle. So immediately he performed a piecemeal resection in larger polyp, and it showed no need for fluid cushion. It's much quicker. You can remove large polyps with the piecemeal resection. But initially reported it has no risk of perforation, but it's not true. Myself, I injured a muscle typically on the fold, but perforation has been reported in certain cases, maybe with the retroflexion, maybe with a tattoo. So it's not perforation free, but much lower risk. I think this is really beneficial for the polyp near the scar. And if you have the SSP that you can see margin and you want to quickly remove, underwater is really way to go. Another benefit of underwater EMR is that you reduces tension. So actually, effectively, you're shrinking your polyp. See, the snare was not fitting, but once you remove the air, the polyp shrunk and it came into the snare. So it actually offered a smaller the diameter when you're performing underwater EMR. So each piece can be a larger chunk if you use a larger snare. Let's look at this polyp. This is the right colon on the fold. It looks like LSD granular type, slightly granular. And since the surface is so readily visible, I did not activate the chroma endoscopy electronic advanced imaging, but it looks like a type 3 and type 4, type 3L, type 4 pit pattern consistent with tubulovenous adenoma. So proceeding with the resection. I wanted to take it out in one piece. So typically with this size, I aim for the center, and the injection had to be just outside the lesion because that would give you the ability to grasp the tissue because of the ridge. If you inject too much more than that, you're doing disservice to yourself because you are making everything flat again. So I control my injection to see how much of the injection is reaching outside this lesion. And then once the surrounding area is lifted enough, I choose the size estimated plus 5 millimeter. If you use a too large of a snare, it's a little more difficult to control. In this case, I think I use a 33 millimeter largest one. With adequate fluid cushion, the larger resection is still safe, but you have to be super careful to ensure that the adequate injection is performed. You see, I'm trying to confirm the margin is outside, snare is outside the lesion to create a negative margin. And then I gather the polyp. I teach fellow, you have to welcome the polyp. You cannot push the snare sheath out. You just capture by gathering. And then this one, I use the endocut so that I can control the cutting and coagulation. However, if you're not so sure how much muscle or if you have a muscle or not, the forced coagulation with full closure may offer a benefit because forced coagulation would not cut through. So endocut, you can cut through anything. You have to be ready for closure if you decide to cut through with endocut. Next. How do you go to next? There you go. So this one's another one that's similar LSD granular type. This time I'm using NBI. And with the colloq style needle, you can use this to manipulate the polyp or stabilize your distance from this area. So you can see much better visualization with a near focus or magnification. If there's any question, that would be the better way. You can use a cap or this type of blunt type device so that you can hold the wall, keep the distance in the same way, control the distance from the lesion. Again, I'm trying to control the amount of injection here. I typically want to inject at the center. You see there's a little chicken skin appearance, probably because of the villus feature. Now, unfortunately, this lesion is kind of more in the rolling over to the other side. So I'm injecting from other side. I cannot really confirm how well I'm injecting. So with a straight view from the anal side, I injected to lift all the polyp up. And if you do that, then the polyp roll over to the other side. But in this case, I cannot really see what's happening beyond the fold. That would be the risky attempt that you may leave something behind. Two things you can do. One is to try to anchor the opposite side, or if the polyp actually roll over to the other side, you should try to do retroflexion to access the polyp so that you can see all the margins. In this case, I did the anchor and pivot. It's keep sliding. The tip did not anchor. So decided, okay, let's do the conventional way. Oh, sorry. So if you push it down, I can see the lateral margin looks okay, but I couldn't confirm the proximal side. But I'm committed. I encircle slowly and endocut. 1, 2. And then you have to see if you get everything and using a snare to control, but I can see there's some lesions left. So what you're going to do from here, there are a couple ways you can do, but this snare is too big. So I changed to the cold snare and ensure that I can capture this tiny area more effectively. And then when you're closing up, you can see there's only tiny polyp remaining, unfortunately, and performed cold snare. You can do avulsion technique with a hot forceps with endocut. And this shows a really nice contrast of the hot snare and the cold snare. No thermal injury versus thermal injury. Immediate bleeding, no bleeding, but the risk for delayed bleeding on the hot forceps. And this one, I finished with the snare tip soft coagulation to demonstrate to my fellow, but I was pretty much sure that the margin was negative. Then click closed to reduce the risk of bleeding. Oops. How do you go next? All right. Okay, for moving on to the ESD, ESD is a new technique. We can do freehand cutting, but peeling this off. And it enables a really large tumor, removing en bloc in one-piece resection. It increases the chance of getting ARZA resection, negative margin resection, so that we can get the really complete tissue, so that we can evaluate the pathology much more precisely. It decreases local recurrence to with the odds ratio of 0.1. But with the snare tip soft coagulation, the recurrence rate is going down, maybe 15% to 6%. So that rate is kind of closing up. But with the precise evaluation of the tissue, the need for additional surgery reduces because certain patients with a cancer can be observed if we completely remove the tumor with negative margin. But this actually has a really steep learning curve. You have to practice before you embark on a clinical case. And there's an increased risk of perforation, which typically we can cope with a clip and closure. Large colorectal lesions is the one that we really struggle with. More than 2 centimeter, a non-polypoid configuration. This is a flat lesion. It's very difficult to capture with the submucosa fibrosis because of the previous biopsy or tattoo. And if there's any presence of risk of cancer in there, we really have to take it out in one piece. But in that case, the ESD would offer a really huge benefit. In 2015, European guideline described ESD as an option, can be considered for difficult lesions more than 20 millimeter with the risk of cancer. In 2019, we discussed what would be the most suitable target for ESD in AGA clinical practice update. Now, in 2022, European guideline actually changed the tone. They appreciated the benefit of ESD, and ESD should be considered. It's not can be. You should consider ESD for certain lesions. So they endorse some of the benefit over other piecemeal resection. This is the criteria we use at Mayo Clinic, Arizona. As for the ESD device, a lot of advancement was made. Traditional DOJ and IT and all these knife is available, flash knife is available, hybrid with a really jet stream injection, combined knife or pro knife. All the knife has pretty much injection capability, reducing time to just perform procedure. Now we have the new device called Speedboat, which has bipolar cutting and coagulation, microwave coagulation capability, which changed some of the landscape of how we do ESD. We have a scissors type, which is a little more slower in advancement, and sometimes it's coagulate too much. The monopolar and bipolar, huge difference actually, and bipolar device is very few. Most commonly used is the gold probe because it is a hemostatic device. It's just really local. So you can just bring it up and without the electrode, we can use it right away. Monopolar device actually create the effect by going through the tissue. So you have to have a really huge mass to concur. So you have to have a really high voltage control it. You have to create a current in between this tissue. Bipolar, on the other hand, has a really controlled distance, and the target tissue is the only one that we have to deal with. So the same effect can be produced by the much lower voltage. So these are type of the devices is being offered. For this reason, with the variety of resistance in fat and muscle and the bone and distance, the computer calculation is really important. So nowadays, the most advanced electrosurgical unit calculate 25,000 times per second to just adjust the electric current. But bipolar has much simpler calculation they can do. So the new approach to the ESD has been proposed in many techniques as coming out, new devices coming out, including the one that I discussed, the bipolar device, and overtube to stabilize the area. The traction device is helping. So the ESD is getting much easier, and adaptation is quicker. This is one of the example of the ESD in rectosigmoid area. I use more thicker, long-lasting solution to lift it up. This is a bipolar device called Speedboat. The electric current only happens between the gold and the bottom away from the white. So these two areas is the one that you have to really feel. So the current, the energy delivery is just exceptional. It cuts without charring. And the really most important part is called microwave coagulation. In between this antenna, actually there's a slower heating happens with the microwave effect. And it causes a slow increase in temperature by creating oscillation of the cells. And it seals the vessel much more completely without the char. So you can see a really nice non-charred resection. That's in turn may affect the healing process, may improve the healing process, maybe less pain after the resection. Those are things that are being investigated, outcomes to be just awaited. So once we take it out, we have to really see the outcome. For ESD, we talk about all this surgical outcome, like R0 resection and unblocked resection and curative resection rate. Curative resection include all these pathological findings to see if there's a risk of lymph node metastasis. That means that whether we can wait and watch or additional surgery may be beneficial. Those are the things that we can really see through the tissue with the informed decision can be made. Specimen orientation is important. This is a resected polyp with negative margin, and we discussed with pathologists which side was positive, which side was cancer. Now, these flat polyp can be difficult to judge how deep the tumor is going. So initially, they separated SM1, SM2, and SM3 to see the risk of lymph node metastasis, but now we judge by depth of invasion. More than 1 millimeter would be the risky signs for lymph node metastasis, but nowadays, more recent report is confirming that depth of invasion by itself cannot be the sole determinant factor. Most important finding is the lymphovascular invasion. So these are the way how they measure how much of the invasion the cancer has below the musculus mucosae. So for the colorectal cancer, SM1 up to 1,000 micron, 1 millimeter invasion are probably safe in the absence of tumor budding, poorly differentiated type, and LVI, lymphovascular invasion. If there's no such findings, up to 1,000 micron would be okay. If those findings are present, then maybe deeper invasion may be able to be watched carefully, but that's still out and not out to the jury to be decided. So I'm sorry it took a long time, but in summary, when you see the lesion, we really have to be able to communicate each other with a standardized way. So we have to say the Paris classification, size and location, and advanced imaging findings. You have to evaluate carefully on the front side and back side, on straight view, retroflex view to see what the lesion is. And adding advanced imaging will be ideal to stratify the treatment method for this certain polyp. Cold snare is really helpful for lesions with less than 9 or 10 millimeter. That's a quick and safe way, and less bleeding risk afterward. Underwater EMR is a useful technique for flat lesion adjacent to scar, or in some way, if you want to do cold snare, underwater EMR is also proposed as well to reduce the risk of bleeding. Conventional EMR is useful to remove sessile flat lesion with targeted negative margin, but to reduce the risk of bleeding on the right colon, clip closure is beneficial, reducing risk by 10 points, 10%. ESD offers high R0 resection rate and potentially saving patient from going to surgery. And it showed lower recurrence rate than EMR, but it needs a lot of training, and you have to be proficient in performing ESD. And ESD is really beneficial for large lesion with high risk features to precisely judge what the lesion is, whether the patient would need additional surgery or can be watched. Post-resection assessment of lesions is really important to guide the patient for future surveillance and potential additional surgery. So thank you so much for your attention. I'm happy to take any questions.
Fukami, por su excelente presentación.
Thank you very much, Dr. Norio Fukami, for your excellent presentation. I believe that it was a very clear-cut presentation, and most doubts that were, most questions that were asked throughout your presentation have already been answered throughout your presentation. Some questions that we do have left after your presentation is, you always close using a clip, that resection area, or do you sometimes leave that without closure?
I'm sorry, could you translate in English?
Yes, they are asking whether
The base of the resection with clips. Do you close it or you just keep it open?
Yes, so that's a good point. So the only benefit shown so far is a larger lesion more than 2 centimeter in the right colon. Right colon definition kind of differs between papers, but in general, closer from splenic flexure. The highest benefit is shown proximal to the hepatic flexure. Cecal lesion more than 2 centimeter is the highest risk for bleeding. So we typically close lesion when we do the EMR, ESD more than 2 centimeter to securely close by high quality closure. The issue with piecemeal resection is that you tend not to close because the uncertainty of the completion of the polypectomy. So if I want to close, I typically want to perform unblocked resection. Between 1 centimeter to 2 centimeter, whether you want to close or not, typically it's decided by the physician who performs the procedure. And if the patient is high risk for bleeding, such as on dual antiplatelet therapy, warfarin anticoagulation therapy, history of bleeding, coming from far away, we try to close with high quality closure, even though the lesion is less than 2 centimeter.
Muy bien.
Very well. What are the criteria that you follow in order to choose a given knife to do the resection?
What criteria do you use to choose the tool or the knife that you're going to use each lesion?
For EMR to ESD or ESD only?
Para SD, para ESD.
ESD.
Oh, for ESD. For ESD, typically in the colon, the tip type, short tip knife is more suitable. So many company has a 1.5 millimeter tip knife, and I prefer speedboat. It can range from several millimeter to 4 millimeter range, but you have to adjust by the cap. Because a speedboat has a coagulation with effective microwave coagulation to coagulate the bleeding, and the cutting abilities is exceptional. But the retroflexion was very difficult to do in the past. So we have been doing more of a speedboat for the lesions we can access on straight view with a tunneling method. And whether when there's a significant retroflexion required, like right colon cecum involving the appendiceal orifice or behind the IC valve, I have been using tip knife, typically dual knife, 1.5 millimeter. Now that may change because a smaller device came out. It's called Speedboat Super Slim. It's compatible with 2.8 millimeter channel, and it can actually retroflex. But rotation is not as good as it used to be. So there's some improvement need to be done. But typically, tip knife I use for the colon ESD, dual knife 1.5, and majority of cases I perform speedboat because of the capability of microwave coagulation and tissue effect.
Gracias. I have a question. have you used hydrodissection or hybrid?
Hybrid knife, yes. So hybrid knife is really exceptional in injection capability. It just expand the semicolon really nicely. Now that is compatible with the saline only. It is FDA approved uses with the saline. That means if you inject saline, it tends to just come back down a little bit. That's not the major drawback. Actually, I love hybrid knife for submucosal endoscopy. I do POEM procedure with hybrid knife most effectively, but the coagulation effect was too much. The current format has really thick electrode. So whenever you try to cut, it coagulates so much. And that I couldn't really get away from it because ESD, you need a precise cutting and minimum coagulation to protect the pathology. So that's the only reason I haven't used for colonic ESD. Now that also may change because hybrid flex is coming out. That is much more flexible fixed length. Now it used to be 0 to 4 millimeter length, but it's now fixed. And it has much smaller electrode. So I'm looking forward to using that hybrid flex knife. Do you use the hybrid knife? Is that why?
Sí, nosotros tenemos aquí el hybrid knife.
Yes, we do have the hybrid knife over here, and we do use it rather frequently. We have another question. In POEM, do you have any experience with speedboat?
So the speedboat for POEM is exceptional when you're making a straight tunnel. It cuts so nicely, coagulates well. Even the myotomy is really nice and smooth. However, the depth control is a little more difficult, and the angulation towards the G junction, when you go through the G junction to the cardia, is the major difficulty I have. So tissue effect is fantastic, but there's some improvement need to be made to make it more usable. So I still do a hybrid POEM procedure with a hybrid knife.
Okay. En casos de lesiones
In
residuales,
cases where you have residual lesions at the margins, do you use argon or do you use any other method to have a better status on the margins?
do you use any kind of energy for the border status?
How do
after
you take
protectomy?
care of the border when it's
After
not,
the
when
EMR.
you left something of the lesion, some of the lesion around? How do you take care of that?
So let's say the scenario is you remove the polyp, there's a little tip edges left, or unsure if you completed. Then there are several ways you can do. If it's a very focal, you can do hot biopsy and use the grab that tissue, pull up, apply endocut energy. That's called avulsion. And that would just effectively take out the area with the cautery. The second way you can do is what you saw, the cold snare. It's much more controllable and grasp this tissue and cut it off. Third is making the smaller hot snare, stiff one, and then control similar to the cold snare, but you apply cautery. Lastly, if you're still unsure, the current most proven technique is snare tip soft coagulation. You extend about 3 to 4 millimeter outside the sheet, and you touch the edges, apply soft coagulation. You can apply a soft coagulation with 80 watts, 50 watts to 80 watts, and you can just briefly blanch out, whitish, and then you're done. You don't have to aggressively coagulate, but you blanch out the margin about 2-3 millimeter.
Okay, and finally, the last question. what is your opinion about the hybrid ISD? Hybrid.
Thank you for the question. Yeah, I am not in favor of hybrid ESD. The reason is that if you are try to complete the ESD, hybrid ESD has a risk of not completing an envelope resection. Central part may not be captured with the snare, and then you create a donut cut. So center is left over, so you ruin all the effort. If the lesion is large, then risk increases. However, if it's a rather smaller lesion, you want to finish quickly, and you dissect off the margin. Let's say this is a 2 centimeter. You cut the margin and then dissect some of the submucosal tissue. Hybrid ESD would cut the time so much. Make sure that they inject beneath the lesion before the snare resection so that you complete with envelope resection. So it's a time-saving strategy for smaller lesion, and sometimes it becomes more of an exit strategy. When you're having so much difficulties, you may have to convert to hybrid to just finish off because you just cannot get to it. You cannot complete the ESD. So those are two ways: strategize, planned and unplanned exit strategy. But I'm not in favor of it.
Okay.
Muchas gracias. Esto nomás lo quiero comentar al público. Tuvimos la oportunidad de tener
I just want to say this to our audience. We have the opportunity to have an expert with us today who knows the best of both worlds, the most traditional part with most modern part. He has a wide experience, without a doubt. It was great that we could have him with us today. And I know that many times when we choose the topic for a given monthly session, there are several aspects to be taken into account. Sometimes we believe that because it's something that we're not going to do, it might not be interesting to us, or maybe it is something that is out of our reach, and therefore it might not be interesting for us. However, I do believe that this was a very interesting way that he showed us his presentation, going from the most basic to the most advanced, because many of the instruments that he mentioned, in particular one of them, the speedboat, is now going to arrive in our country. And in theory, it is going to make it easier, obviously, with certain things to be observed. It is thought that it is going to make some procedures easier to be done. And even though it might not be a topic that right now might not be interesting, I'm not talking about this topic in particular, maybe other topics to come throughout the year. Let's take into account that it is great to be updated. Number two, we need to at least know the indications and to know what can be done if it is not us doing it. We are very glad that we had several followers join us today from Central and South America, even from Chile. And the idea is that this continues on growing, that we receive more and more people and more questions and more. For now, we would like to thank Dr. Norio Fukami for his excellent presentation.
for your excellent lecture.
Thank you so much.
And
I'll be
have a
back
good night.
anytime if you like. Thank you. Have a good night.
Les pido por favor que no se desconecten. Voy a hacer
I would
algunos
like to ask that you do not disconnect just yet. I am going to do a couple of announcements that are very important for our partners. And I would like to show you how probably you already realized that there were some changes in our webpage. Therefore, I would like to explain to you some of the additions that we had to do in comparison to previous versions. And I would also like to tell you that many of these new sections are the result of the work done by many of you, as well as we had to redo the course for the certificate exam. It was the work done by several of our associates. So we will take a look at our screen today. Of our website. Forgive me for repeating myself. This is for the AMEG website. It looks much more dynamic, and I was very much interested in mentioning you the new parts, the changes. In this part over here, we have the main events, the main future events, the most the ones that are closest. These are shown here. These are the ones that are coming in shortly. And also we added the beginning story, and we added also this tab over here. This was a joint an idea. Course for the certificate exam, the Endoforum. Endoforum, the idea is that you as members, that you send some of your trouble cases. This is a 60-year-old patient with anemia, and you can see using the capsule that there are hundreds of angiostatic lesions, and this is sent by a fellow member requesting help in terms of possible diagnosis and how to treat this patient. This is just an example, but this is an option that will be available for you whenever you request it. And we go back to this homepage, webpage. Scholarships and training opportunities. This is an area where we will post any information that we might receive, and any information that you might want to share with us, we will post it here. In the scholarships, we have this one that was launched today. This is a scholarship for women in endoscopy. And this is sponsored by the program of Endoscopy on Air. And if you click on more information, you will see what the requisites are. So periodically, please do check this section, because we will continue on posting any type of scholarships, courses, due dates for any work or awards abroad. And in terms of formal training, you will have here the number of spaces available, the dates for people who want to do training in endoscopy, and for those who might be interested in doing fellowships on endoscopic ultrasound, for instance. Another new tab is this one over here, which is a database. This is still in the making. We already have a protocol that we are designing. We are creating a database so that any member who might have a patient who fulfills the criterion that we want to fulfill for a multicentric study, it might meet not only at the national level, but also international level. We will have people interested coming from Central and South America. We will have the information posted here, and you can just fill in this database in accordance to the criterion posted, the inclusion criterion for each work. And now here we will have the information. Here, let me go back a little bit. And we have links with the societies or associations that we are linked to. You can see that we have most of the ones that have a link with us, including from South America, from Europe, and from the United States. Therefore, you have the link over here for all of these societies. that obviously are linked to us. And a new homepage is this one, which is patient information for patients. This is, you can see what an endoscopic capsule is, what it is about, the requisites, and so on, and a description in non-medical terms so that the patients understand what each of these procedures comply. It makes it even more important for you to be part of our directory, because patients will have this available for them. I would like to go back to the main page once again. And in particular here, I would like for you to pay attention to this area over here. Here it says leader. You might remember the leader courses that were carried out ever since our president, Clara Luz Martinez, was in office. And they usually were done in one institution and they were only regarding one topic. Last year, we only had 2. The main change that we did this time around is that instead of having 3 2-day courses per year, what we will have is now that my aide tells me, here it is. This is what we will have. It is going to be called a leader program, not a leader course, because it is going to include several topics. You can see some of the topics over here, maybe 1 or 2 missing. These are coordinated by Dr. Ángel Reyes Dorantes. These are the topics. It's as if once each of these topics, it used to be 1 leader course. Now we have 11 leader courses. We will have them available online. They will last from 6 to 11 days, 1 hour per day. And the last 2 days will be for practice on that same subject, and that is included in the cost. So what you see in this webpage is the one for the capsule, chapter 1, and it is going to be the one that it will be the first one. So instead of just signing up for 1, 2, or maybe 3, now you can sign up to 11. Because we have made it so that we have them available twice a year, and you can have access to them at either of those times during the year. And another thing is that I would like to show you is that each month you have been receiving some emails with this calendar, this monthly calendar where we have dates and what dates the events are going to take place. It will be available in the webpage, and in your email you already have this. All of this is already being programmed. I would just like to draw attention to the fact that each month we will have different activities, but something that is very important, because it's not, it's something that is repetitive. It is something that will continue on taking place every Wednesday, either at 8 or 9 p.m., depending on our moderator. We will have the journal club, which is going to be about endoscopic ultrasound when we have our presenter, Felix Telles. This is every other Wednesday with Dr. Sergio Sanchez Luna from Birmingham in Alabama. And they will be discussing topics, everything that isn't ultrasound, everything regarding endoscopy, except ultrasound. That will be Dr. Felix Telles. Even though we will have it available, I just wanted to keep in mind that this is always going to be like this. On Wednesdays, we will always have a journal club, either with Dr. Sergio Sanchez or with Dr. Felix Telles, whether it is announced or not, and we will announce it, but if we forget or if we have technical difficulties, we will always have a session on Wednesday. And finally, I just wanted to remind you or let you know about the next monthly session, which will take place March 7, updates on cholangioscopy by Dr. Alberto Baptista from Caracas, Venezuela. If you're thinking, oh, once again, cholangioscopy, no, do not think that this is going to be boring, because take a look. We have more and more devices with different diameters and different accessories, and our competitors in this area of cholangioscopy is growing. So I would like to invite you to please be in this session, because this is not going to be what you already know. This is going to be different. Having said that, I believe I would like to close this session. If there are still things that can be improved, please let us know to the email for associates or members. You know already the email, Asociados AMEG, that's where you can post your questions or comments. Having said that, I would like to finish this session. Thank you very much and have a...
Inscríbete a Endorregia 2024 y a nuestro hands-on y no te pierdas la oportunidad de ser parte de este curso que se impartirá en la ciudad de Monterrey, Nuevo León. Este emocionante evento se llevará a cabo los días 1 y 2 de marzo en el prestigioso Hospital Ángeles Valle Oriente. Endorregia 2024 es un evento con ponentes de renombre internacional que no puedes dejar pasar. En esta ocasión nos acompañan los profesores internacionales Dr. Sig Pichamol Girampiñón, Dr. Sergio Sánchez Luna, Dr. Mohamed Othman, Dr. Barham Abudayeh y el Dr. Román Turró Arau, quienes compartirán su amplio conocimiento y experiencia. El Hospital Ángeles Valle Oriente, reconocido por su excelencia en infraestructura y tecnología médica, será el escenario perfecto para este evento. En Endorregia 2024 tendrás la oportunidad única de participar en el curso Hands-On, que es 100% práctico. El método te permitirá perfeccionar tus habilidades bajo la guía de expertos en la materia. Esta experiencia práctica enriquecerá tu formación profesional y te permitirá enfrentar los desafíos de la endoscopía de manera efectiva. No te lo pierdas. Cupo limitado.